Hello, I'm Dr. Maurie Markman from City of Hope, and I'd like to briefly discuss, I think, an absolutely fascinating paper and one that deals with an important question, but also I think demonstrates, quite frankly, the value of retrospective studies looking at data that has been collected for other purposes that might inform future optimization of our care. So, this was a paper published in JAMA Surgery earlier this year entitled Bowel Resection Outcomes in Ovarian Cancer Cytoreductive Surgery by Surgeon Specialty. Now, this is obviously an interesting topic in general. Gets into some of the questions that go on in oncology in general about who is the best specialty to deliver a certain type of care. Certainly, that has been going on for decades and decades. But again, the question here is optimization of care. And here's a very specific question, which is cytoreductive surgery in ovarian cancer. So, what the investigators looked at was data from the American College of Surgeons National Surgical Quality Improvement Program. It was a data set from 2012 to 2020. So, they looked at three different groups. One, surgery performed by gynecologic oncologists. Two, surgery performed by general surgeons. Again, we're obviously talking about ovarian cancer. And three, and this is the point, two surgeon team approach. So, I assume in the database, and I'm not familiar with the actual database, it says this was one surgeon carried out it, might have had fellows, but one attending surgeon, or two surgeons directly involved, or maybe again, it could be that the fellows would be considered the surgeons. The point is they use the term two surgeon team, and what they demonstrated here, and as wouldn't be surprised that the majority of the cases actually performed by the gynecologic oncologist, or 1,200, and 17 cases by the gynecologic oncologist out of a total of 1,810 performed. There were 97 cases performed by general surgeons, relatively small within this database, but 496 cases performed by two surgeon teams. So that was about a quarter of the patients. 67% were gynecologic oncologists, 5% were performed by general surgeons, and 27% by the two surgical teams. But here's a credible bottom line. This is objective data that in that database. If one looked at the question of anastomotic leak, there was 3.6% for the gynecologic oncologists. That's within this whole database. 5.2% for general surgeons. But for the two surgical teams, the risk of anastomotic leak was 0.4%. And as you can imagine, that difference between the individual surgeons, whether a gynecologic oncologist, surgical oncologist, and the two surgeon teams was highly statistically significant, with a p-value of 0.003. The authors conclude, this is their wording now, the leak rate was found to be lower when two surgeons participated in the case, regardless of the surgical specialty. These results suggest that team-based care improves surgical outcomes. Again, provocative data. I'm not a surgeon. I will not comment any further. But I think this is the type of data, when you see this, a retrospective analysis, I think it's very important, in this case, for the surgical community, in the case of the hospitals that are looking at their own quality, to say, perhaps, just perhaps, if we're not doing two surgical teams, we should look at our own data. Two surgeons per team, we should look at our own data and perhaps maybe require, or at least recommend it. Again, very interesting data, provocative data, demonstrates the value of retrospective analyses, in my opinion, and then asking the questions, if you take this data, how can we use that potentially to improve the quality of the care we're providing our patients? And I thank you for your attention.